Hello and welcome. This session today is about the Embryoscope, a breakthrough in IVF technology. Thank you to Fertilitech for supporting this conversation, and thank you, our audience, for joining us. Please share your views and continue the conversation with us on Twitter and Facebook at Fertility Planit with hashtag FPLA14. We'd love to hear from you. Go to fertilityplanet.com to find speaker bios, Twitter handles, and to book appointments with any of our speakers. It's my pleasure to introduce Dr. Jason Barrett, embryologist, embryology laboratory director, research scientist, and Southern California Reproductive Center. Thank you, Dr. Barrett.
All right, well, you want me to start the timer? All right. There aren't a lot of you here, so as I do the initial presentation and such, I'll go through it, and then we'll have questions and answers and those type of things happen after that, so we can nail down to specific things that you guys want to learn about. So I'm going to give this as a fairly casual conversation after I go through everything. I'm going to show some videos and things like that, and talk about what we do with the Embryoscope to help patients get pregnant. So I'm going to talk about the morphokinetic analysis of developing embryos or getting made, if you want to use a Italian term. We find the embryos that actually are going to make the babies. We isolate them specifically and transfer those ones only so we can lead to a normal, healthy singleton pregnancy at a time. All right, so the Embryoscope. So normally we culture eggs and embryos in incubators of some type. The normal way is we take them out once a day, look at them, take pictures of them usually, and write down a bunch of information about them. And we monitor them only one time per day. That minimizes the times that they come out and they are not in the most optimal growth environment. If you can imagine, inside of you, it's a perfect situation, the right temperature, right humidity, right hormones running around and all the fluids. Well, we have to pick the best fluid that we can outside the body. We have to maintain the temperature really well. We have to maintain the gas levels in the best way also. Also, we can't expose them to a bunch of light. As you can imagine, they have no protection against any light. And UV light, as we see it, we have skin that has pigments in it so that it blocks UV light from damaging our DNA. They have one copy of the DNA when they start out, no protection whatsoever, so they need to be in this nice, dark environment. So what we've actually found is that the Embryoscope, so they integrated an incubator with a camera and made the gas levels and everything adjustable to what we needed specifically. So it integrates being able to take a lot more pictures than one per day, but not take it out of that perfect environment, and at the same time being able to keep that development and the selection of the individual embryos the best that it can be. So when we look inside this, there's 100 daily observations. So about every 10 to 15 minutes, it takes a picture of every single embryo. But we don't have to take them out. So we get all the information about how they're moving along in their development, but don't have to take them out. It takes 7 focal planes, so we sort of have an up and down 3-dimensional picture of each one of them, so we can look at all the individual cells. So we get about 3,850 images during 5 days of growth and development at the beginning, which allows us to make these nice little videos, which I'm going to show you a couple of, so that we can watch every single division of the embryo and make sure that it did happen normally, or if it did not, why we don't choose to use those embryos. So it allows us very, very tight controlled conditions. The temperature is maintained very, very specifically down to a 0.1 degree temperature. The gas source is a certified gas source. It goes in there and gets mixed and checked constantly during the thing, and they have very big monitoring systems that allow us to see it and make sure that it's right. And then we have very, very tightly controlled consumables, or the dishes and the media and the oil and everything else we use is extremely tested ahead of time, tested with mouse embryos to make sure that it's not going to be toxic and all those things. So we have these situations that allow us to have very, very tightly controlled environment. So really what it is a big screen hooked to the microscope itself and hooked to the incubator. And so we get these pictures of no pointer, but that's okay. But nonetheless, It allows us to look at every single embryo one at a time. So what I'm going to do is I'm going to come over here for a second. I'm going to point inside this one box. There's one single egg sitting there. That single egg is going to be monitored, and we follow them in their development as they go along and see how they change over time. Down here, you can actually see that this embryo has divided to 2 cells. That one over there has divided to something around 5 cells already. So we can follow them all at the same time. We can focus up and down throughout and see all their developmental changes over time. Okay, so before you start the video, I'm going to say that, well, there we go, automatic. Whoa, no, we got to go back. I got to go back to the normal first. We can't look at the abnormal. All right, so this is the nice blastocyst. So what you're going to do is down in that corner, you're not going to really see it much, but there's a timer down there, and that's telling us how we've gone along in its development. Over here, it happens to mention what well it's in, which means what number embryo it is. And we're going to watch this one. So over the next 28 seconds or so, we're going to actually watch it go from the moment that it was about 3 hours outside the body all the way to the first 5 to 6 days of development. So to go ahead and start it. So there it goes. 2 pronuclei form. That's the normal way. 2 cells divide, then to 4 cells it divides, to 8 cells it divides, and then it begins to divide. Focus one more time. It comes together in a morula and then develops into a blastocyst and starts to expand and try to get its way out to hatch. So leave it there for 1 second. So you can actually see some of it starting to come out of the shell, because even the human, we initially start out in a shell. We call it the zona pellucida. It protects the egg initially, and so the embryo does need to get out of it. So for the first approximately 5 days, it lives in there nice and safe and protected, and only at that point does it actually work its way out. As it works its way out, that's when it opens up the opportunity to implant in the uterine lining. So that's what the blastocyst looks like. So 5 days of development, 116 hours or so on that one, went by, and tons of pictures, make these nice little videos. Now that's the way it's supposed to. So I'm going to ask you to play it one more time just so we have a baseline of things. So initially what we'll see is 2 pronuclei develop. So that's a set of chromosomes from each, the man and the woman. 2 cells, 4 cells, and every single time it should divide evenly. It should go from 1 to 2, 2 to 4, 4 to 8. Not all embryos do that, as we will see. Forms a morula, develops to a blastocyst, and then tries to hatch its way out. So that's what we want. Everything should happen exactly like that. So we'll click along to the next one. So this one does something abnormal. So you can tell it's going to go from 1 cell to 3 cells. So there's the 2 pronuclei showing us that it was normal at that point. But it goes from 1 cell, gets a little wobbly, can't figure out what to do, and then what you see is you see 1, 2, 3. 3 is not a normal number. It doesn't divide evenly. Our genetics need to replicate and divide equally each time. That didn't do it. We speed up the rest of the video, and it goes along. It forms multiple cells. It forms a blastocyst. Not a great one, but it does still form a blastocyst, so it potentially would still be transferred, and you can actually see it trying to hatch out down there at the bottom. So if you didn't have an embryoscope, you would not know that it made that abnormal division from 1 cell to 3 cells. It's not a time point in which you would ever have pulled it out. 2, you would never know what it was before and what it is after, how the journey happened to get there. Because if we only pulled it out and it was at 5 cells, we wouldn't actually know whether it had gotten there normally or was in the middle of a division, or if it had done something abnormal. So this embryoscope, because it's constantly taking the pictures, it doesn't require us to take anything out or compromise any part of its development. It gets the best environment to develop, we get the most information, and therefore we lead to picking the single best embryo. In this case, we would go back, watch the video, make sure that it actually did or did not divide correctly as it goes along. This one did not. We would not pick it for transfer unless we absolutely had nothing else, because the potential of an embryo like that is approximately 1 to 2% to make a baby, versus the first one that you saw, it's about 75 to 80% chance of making a baby. So we really use the technology to help us pick out the most optimal one that has the real chance. It's really not beneficial for us to put back an embryo that is potentially abnormal. It doesn't help you along in your journey, and it really doesn't help us succeed for you. All right, so we'll kick along to the next picture, or next slide. And this one moves along, and it gets to the 2 cell, fairly nice, even, everything else, 2 pronuclei, then 2 cells. So there's the 2 cells, and all of a sudden, though, it divides to 5. So one of the two did something abnormal, divided to a 3 in the other one. So it goes along, it still divides, keeps dividing, forms a blastocyst. Not the most beautiful one, but it still did form a blastocyst. So we need to know that it did something abnormal early in its development. And once again, the embryoscope is the only way to know that. You need time-lapse videography where you can see its development constantly throughout. So we'll kick on to the next one. So this one actually has a bit of a genetic issue. So as we kick along here, we see 2 pronuclei develop in the middle, and then it divides to 2 cells. But in this bottom one, it's very hard to see up in here. Sorry, in a bright room such as this. The bottom of the 2 cells had many little spots in it. They were called nuclei. So it had so many that it probably had replicated the DNA incorrectly, and it was dividing and fragmenting apart. So it did have DNA in there. It was dividing correctly. Unfortunately, it had multiple copies of it, or potentially fractured pieces and copies of it. It did go and form a blastocyst, as you can see, at about 113 hours. So it did succeed in making an embryo. However, at the 2-cell stage, half of it was probably genetically abnormal. So once again, only if you use time-lapse videography would you ever even know that the embryo did this, as you would never pull it out at that stage of development. And 2, you can watch how those individual cells develop as it goes along and eliminate them from being transferred. Once again, this would have a very, very low chance of success in order to be able to implant and produce a child. So we eliminate things that are like this. All right, so when we watch this video in a second, you're going to look at all 4 of those, and it's in real time. This is one case, one person. They had 4 of them isolated. We'll play it one more time after this, but nonetheless, so we're going to go along, we're going to watch them all together, and we're going to try to look and see which one we would pick, or which 2 we would pick in order to make the baby. So we will go ahead and watch it. So this first time through, we'll just get there that all of them end up forming blastocysts, as you can see. They all make it to the end. So this is what the last picture looks like. So we'll go ahead and watch their development as we do it one more time. So there you go. Thank you. All right, so which ones divide to 2 cells first? And that is up here and down there. So there and there, right? So those are the first 2 that did it. And they're both at 2 cells. But this one has 2 little things in it, multinucleated, not what we want to develop. It also divided from 1 to 5 cells. This one down here is stuck at 4 cells at the moment and then divides on. We picked up the speed of the picture just so we can get to the end. And so we go along in their development. So which ones would you pick? The 2 that divided first, that had multinucleation. That one divided incorrectly at one of the early stages. So you'd want to pick one of these outside 2. And so the upper for you, for me, upper left, for you, upper right. This one would be one of the best choices, but I would actually pick this one. You can sort of see this area here. It's actually working its way out of the shell. So if you play it one more time, what you do is you don't always pick the fastest thing. You don't always pick the most normal looking thing at that moment in time if you looked only once. But with this what's the timing on this one? Well, you can see we're at about 38 hours right there. So that's, not quite the full 2 days yet at that point, but then we speed it up here just so we can get to the end. But as you can see, this one is not the first one to divide. It's not the first one to actually get to being a blastocyst. It's not the first one to make it to 4 cells or 8 cells, but it ended up being the actual best one for the potential of a baby. Those 2 would have a 1 to 3% chance of success. These 2 would have between 60 and 70% chance of success. So what the technology allows us to do is look at these little videos and watch every single cell division as it goes along and pick out the ones that are doing it in a normal way rather than just randomly looking once a day and not knowing how it got there or what time point. Because if we look, 4 hours before this picture, that's when we get to one shot, we may have picked a different embryo. But so the time lapse allows us to do it repeatedly over and over without ever taking the embryos out and picking the best one. So that's what we spend a decent amount of time doing. The technology also allows you to time all of those individual events. And so you can look at the time that it got to 2 cells, the time that it got to 3 cells, the time that it got to 4 cells and to 5 cells. You can look at the time between when it was 2 cells and when it starts to divide again, starting for the 3rd and the 4th cell. You can look at the time that it divides from 2 all the way to 4 to see if it's synchronous. Is it dividing correctly during the period of time? Did it rest long enough between 2 cells and 4 cells to replicate the DNA one time and to divide correctly? So these time points actually start to matter as to, is it on the normal track or is it off track, too fast or too slow? And so the technology allows you to do that, and you can mark down when it's 1 cell, 2 cells, 3 cells, 4 cells, and all the way along. And you can look at down here, you can actually see an activity bar. So you can see that it peaks out as it's getting ready to divide from 1 to 2 cells. It peaks out when it's going from 2 to 3 and to 4. And then it peaks out again when it's dividing from 4 to 8. The embryoscope helps you determine, as development goes along, when it was most active, when it was changing the most. And in this case, it's dividing from 1 to 2, and 2 to 3, and 2 to 4, to 5, to 6, 7 to 8. And as it does that, it goes through that. You want to have a very nice tight change from whatever cells you were to doubling, but you want to have a rest period of somewhere around 11 to 12 hours in between to replicate the DNA. So remember, at this point, we only have one full copy of the DNA. So it's very, very delicate. It's in a very, very sensitive state. You would never want to take it out and make sure that it's dividing at the right time or see how long it sat at that. It's just so hypersensitive at that point. So moving along, we sit there with each one individually each time in the thing. We have codes for different patients. We can look at every single one. We can pick out some things down here in the corner where we can pick out those are the ones that may develop normally, may not have developed normally, ones that we want to transfer and ones that we want to freeze. So they can all be labeled up over on my left-hand side, your right-hand side. You can see the activity bars, and we can pick out when they divided at each time point, and we can follow and be very careful about each one of the individual embryos and pick the best one. So in this case, my direct boss and one of the owners of the place, this is him, Dr. David Hill, and I, looking at one patient, and up on the screen you can see 3 embryos in the top row and 4 in the bottom row. We're looking at them, reviewing and making the best decisions. The embryos themselves are sitting right there inside that machine, and you can see there's one spot. So they're sitting in this slide, in this case 7 embryos sitting in there, and we're analyzing each one of them. But we don't have to take them out. And we can see every time point about every 10 to 15 minutes as it's been developing. And we can make the best choice to pick out the best single embryo. So here this one plays. So this one is just a few more. It's 11 of them, all moving along. And so we look at each one of them as they progress and see which ones are developing the correct amount of time, which ones are resting the appropriate amount of time, and are synchronous, meaning making their divisions. Which ones form morula at the earlier stage, which ones then begin to develop to blastocysts, and which ones then begin to hatch out. So in this picture I'm going to show you, there's this thing that's around here that's called the zona pellucida. That's the shell. This one doesn't go on and develop, whereas this one went on and developed and stretched that shell that was there and is starting to hatch out. So we can see a lot more detail, we can get a lot more information, and yet we don't have to take them out of the perfect optimal environment for their development. So we sit there and analyze these things and look at, did it look okay? Was it morphologically? Did it do any of the bad divisions, 1 to 3 or 2 to 5 or something like that? We also find out whether it actually has made it to certain developmental time points at the correct amount of time. Did it take the right amount of time to replicate the DNA, divide, replicate, and divide? And did it do anything too fast or too slow? And we can give them letter grades or just qualitative grades at that point in order to pick out which ones are the best ones and which one to pick to transfer. So as I said, we turn some of them blue, ones that we're going to freeze and put away for a later time. We put some of them in green, ones that we're going to transfer at that point, and then some, in this case, there's some red dots up here. That one was not going to be able to be transferred. It did one of the abnormal developments. So we can go through these analyses and look at everything without ever disturbing the embryo's development. So the embryoscope allows for non-invasive observation of embryo development using time-lapse technology while still maintaining highly controllable culture conditions. So the best incubator with the best microscope, and yet we don't have to take them out. It's continuous observation, produces images that demonstrate time-related developmental differences with significant consequences that definitely affect pregnancy. As I said, if it does one of the abnormal divisions very early on, it's really got almost no chance of success. I would rather put something back that might be a little bit slower or maybe not developing in exactly the same speed, but you don't want to get there too fast. It's one of the things that, unfortunately, embryos sometimes have unregulated division. Those are not the ones that will make a baby. And so last, the morphokinetic analysis developing embryos are made is crucial for selecting the single most optimal embryo for transfer with more accuracy than ever before. It allows us to really get down to what is the single best embryo that a patient has, putting back one at a time to lead to the most normal pregnancy possible with the least potential for any abnormalities in development. And then also the safest pregnancy to have is a singleton. Our bodies technically are designed for that, and therefore one at a time, healthy, normal, simple delivery for a normal, healthy baby. So that's it for the conclusion of those things. However, I'm going to show you where, to a degree, the technology is going in a little bit of a way. So yes, it's a very old phone, but nonetheless, somebody can look in on the embryos to make sure everything is happening safely, and it allows you to do that. At the moment, Europeans are the ones who are mostly doing this, but they are able to look in and see and make sure development is going along live as it's happening. So it's a very nice technology. Ultimately, it's going to allow more individuals with much more knowledge about development and things like to give a second opinion, to look at a thing and to help you. And it also allows you, when you do an initial attempt at fertilization, you can actually peek in a little later that evening and make sure things are still developing in the right way, which is very positive for us in the lab, because we're doing everything we can to make it happen and make the best outcome. And we get very, very nervous about somebody else's materials that we're taking care of for the first little while. So we like to peek in every once in a while and just make sure things are progressing. So the video plays, that's perfect. This is actually the video of the very first embryo that we put in our embryoscope that made a baby and is running around at this point of, I don't know, a little over 1 at this point, running around. It was not the fastest embryo. It wasn't the most beautiful embryo, but it was the one that met all the time points, did the things correctly, and ultimately led to a normal, healthy singleton pregnancy. So on the left-hand side are the people that I work with, Dr. Hill, my boss, and then all the people who get to work with me in the lab, or maybe I get to work with them, might be the right way of saying it, the people that actually hands-on do a ton of the work. And then over on the other side are the physicians of Southern California Reproductive Center, Dr. Mark Suri, Hal Danzer, Shaheen Gadir, Wendy Chang, and Carrie Wambach. So as you can see, the embryo's coming along. It's at that cellular stage. It's now forming a morula. It's coming together. All the cells are communicating with each other, deciding who's going to become the baby itself, who's going to become the other tissues, and then it forms a blastocyst, and it moved and expanded and tried to push its way out. So that was the first 114 hours of that one. So we are babysitters for about 6 days in the total, but it's a very, very important part of the process, and we use the embryoscope and the time-lapse technology to eliminate the ones that aren't going to lead to a normal pregnancy, but find the ones that are and only use those. So that's it for me on the lecture side of this. With 23 minutes and 57 seconds to go, it's going to be time for you guys to be able to ask questions and do those things. So thank you for coming and listening.
Thank you, Dr. Barrett. My question would be about your facility. Do you solely work with the other doctors that you just mentioned on the right, or you provide the service for many facilities?
All right, so the laboratory, which I am the actual director of, which is called ART Reproductive Center, we are teamed up with what is called Roxbury Surgery Center, and it is in the same building on the same floor as Southern California Reproductive Center. However, we don't just serve those 5 doctors over there. We serve a total of 19 different physicians at our place. So many, many, many physicians who know that we do everything in our power to make babies come to our center rather than have their own centers or rather use somebody else. So yes, pretty much everybody at UCLA, everybody at Cedars-Sinai, and then 4 individual 2-partner practices and a couple other single practice people all come to us because they want to use the best lab that they possibly can for their patients. And so we try to maintain the highest level of quality, most information back and forth, easiest opportunity for the patients to come through and get the best result out of it. So yes, we work with quite a few physicians in our single practice.
And what would be your competition in this field? Or who would be your competition?
So I paused for a second to try to decide how to answer that. So I'll say it this way. I actually don't have competition. So for me, as directing the laboratory itself and all the wonderful people that work with me, there really isn't a direct competitor to us. Yes, there are some other laboratories that are in the area, but most of them are hooked to individual physician practices or groups. And many of them do a very, very good job, no question. But no one really comes to our center directly for me. As I'm not a physician, I'm not the one who you get referred to come see. I'm just the guy who actually does all the work in the lab to make the baby. So technically there isn't a direct competition to me and to the group on the left-hand side of the screen. Whereas, yes, there are plenty of other physicians you can go to and get different nurse groups, different things that would help you, different blood draw places. People use different machines for the endocrinology testing, what their office looks like, where their office might be. You might find somebody else who's technically competition to the 5 doctors who are over there, but we really do try to maintain the best center for you to come to for the physicians. And because the physicians are in the same building on the same floor right beside the lab, it's really convenient to go back and forth if we use us. So technically, I don't really want to say I have a lot of competition. We do everything in our power to give the best care to whoever is there. We don't care whether it's our internal docs or one of the outside docs. We are going to treat their patient exactly the same, the best way possible.
Thank you.
Thank you. I'm a patient of the Southern California Reproductive Center. In the last 3 months, I transferred 2 hatching blasts each time, and they all failed. My question is, one of them was classed as good and 3 were classed as fair. Can you explain the difference between a good and a fair hatching blast, please?
Yes, I can. I'm sorry to hear that. Let's make sure we can make this happen. But to give you an idea, I'll use the one picture that's up here, and then we'll talk about it. So as you're saying, we actually sit there and grade the embryos. This is not a negative thing. It's just so that we can pick out which ones have the most potential. And as I said, the Embryoscope allows us to have a lot more information in making that grade determination versus looking at them only once a day. However, once a day, we have a lot of knowledge. I mean, I've been doing this for about 15 years now, so I pretty much can pick out which ones are the best and not. So we used to use a grade system, A, B, C, D, E. Now we use a good, fair, poor, as you're sort of getting at. So we clumped together basically the top 2 quality ones, the A's and the B's. We gave the C's as the fair, and then the other things are what are called poor. And unfortunately, those ones do happen. But this is the body and the embryo developing itself. It is selecting out whether it will work or not. So I'm going to use this as an example. So there's a pile of cells that are right here. Those are the inner cell mass. Those are the ones that are actually going to make the baby itself. There's a bunch of cells that are around the outside, those little bumps here and there. Those are trophectoderm. Those are going to make the extra embryonic tissues, placenta and other tissues like that. And then this is that shell that I talked about around the outside. That's the zona pellucida. In this case, there is a very nice number of cells there. They're all nice and big and plump. So that is a beautiful inner cell mass. That is definitely a grade A or a good quality one. You see all these trophectoderm cells around here, and they're remember, this is in 3 dimensions. It's a little ball of cells. It's not just one slice through it. We can see that there's plenty of good cells there. We want there to be plenty of good cells because those are the ones that are going to control implanting in the uterus. So this one would be considered a good or an A quality blastocyst. I can't actually see any hatching in this single picture, in this single plane, but if they were poking out of that shell, that would be hatching. So this is what we would call a top quality, an A grade, or a good quality embryo. The fair ones will either have fewer cells inside that mass itself, maybe half the size approximately of that cell, or have fewer cells around there, so they stretch a little bit farther. So it doesn't have as many cells to grab on. So that's what a fair quality would be. Not quite as good as this, but still has a very good chance. So at our center, basically the highest quality ones have somewhere in that 60 to 70% chance for that one single embryo. The fair ones have about half that level of success. The poor ones have a very low chance of success. Although we do transfer the pores, if that is all that we have, we are still going to give it the shot that we can. But we always are really trying to optimize the embryo development so that we can get those top quality embryos. That's one of the things the Embryoscope does. It controls that environment perfectly for it. We basically don't have to take it out, and yet we get all the information that we need to make the best decision.
Thank you. Oh, excuse me. Thank you.
Thank you, Jason.
Yep.
I'm Catherine DeVagarte. Spent many hours in your lab. It's a wonderful lab when I was a fellow, before you were there.
Yep.
And just wanted to...
Still
two
a very
questions.
good lab.
I know. It's an amazing lab. And two questions for you. Number one, the Embryoscope, has there been any studies, there are randomized studies between genetic testing and Embryoscope and pregnancy rates to see if it truly impacts pregnancy rate? And would you pick that embryo that was genetically normal? That was number one.
Okay, well, let's stop there with the first one, because this one could be
Yeah.
16 minutes worth of discussion. It won't be. We'll do it faster than that. Okay, so time-lapse technology actually does not test the DNA that's inside that embryo. There is a technique that we can do that. That's called PGD or PGS, or pre-implantation genetic screening or diagnosis. That's where we take a few of these trophectoderm cells out. We send them to a genetics lab overnight. They run it really quickly, and they tell us, do they have the right number of chromosomes in those cells? If it has the right number of chromosomes, we know that it still has great potential to make a baby, a normal one. If it comes back saying that one of the chromosomes is missing, or there's an extra copy of the chromosome, or there's complicated back and forth missing regions and such, those are not embryos that we put back. They're abnormal. They're not going to lead to a normal, healthy baby anyway. There's no reason for us to put them back. So that's genetic testing. But as I said, I actually have to take something away from the embryo to do that. So I have to be invasive. I have to take something away. Although the way we do it now with trophectoderm biopsy at this basically stage, it's very, very little possibility of damage. However, I still am doing something that it wouldn't be used to. So there's always just the slightest risk. We say there's approximately a 1% risk of us causing any damage whatsoever to do the thing. However, we gain a tremendous amount of knowledge about the exact genetics of that individual embryo. We can do it for all of them in a single case for that patient. However, the time-lapse technology is starting to come along to where it can show those abnormal time points in development, such as it took too long to get to some developmental time point, meaning let's say form a blastocyst, which that's what that is. If it took too long to get there, it's much more likely to be genetically abnormal. If it went too fast and got there way too quickly, it's more likely to be genetically abnormal. But time-lapse technology cannot actually look at the DNA, so we can't know with 100% confidence. But there are some papers who have started to come out that are looking at specific time points, usually in a what is called an additive model, meaning the time point it got to some of the cell stages of the 2 cells, the 4 cells, the 8 cells, maybe the 5 cell stage. Those ones, when you look in combination, is it doing the right thing at all the time points? And if it's yes, 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 it's most likely to be normal. If it's yes, no, yes, yes, well, that one means it's slightly less likely to be normal. So it can be used to help select out the ones that are most optimal, which is what we really use it for, the time point development that it goes to and it meets. And as long as it's meeting all the different time points, we give it the best chance, the highest quality embryo, the good ones, and those are the ones we want to put back first. We don't throw away the other ones because this isn't 100% accurate to pick out genetics. As I said, it can't look at the DNA, can't count the chromosomes, but it can give us an idea. Some of the newest stuff that's been published actually shows that the time that you get to first forming a blastocyst, that's when this cavity, this empty area that you see there, when they first start to form that cavity, and when they make it to a full cavity, which is what this one is, it's fully filled, that shell. Those 2 time points, when combined in a certain way, actually are very, very predictive of whether it's most likely genetically normal or abnormal. If it meets those 2 time points, it's about 65% accurate that the DNA is correct. If it doesn't meet one of those 2, it's only about 35% chance that it's normal. And if it doesn't meet either of those, it has probably less than a 5% chance of being normal. So we can use these things to help us choose which ones we would want as the most optimal. We want things to meet the time points. We want them to form those little cavities and form the development of the blastocyst at the right time points. And if we do that, we can pick out the likelihood of it being more normal. But we can't be 100% positive unless we actually pull out some of those cells. So that's what it helps, but it can't actually say things are normal.
Thank you for that. And the second question was, I know this is expensive and you can only put 1 patient at a time, is my understanding, in one of these. How do you pick which patient gets the scope, or do you make a reservation, or how does that work?
Okay, so we can actually do more than 1 patient at a time in this wonderful little machine. there are actually 6 slides or 6 sections inside the thing where we can put up to 12 embryos in each one of those. So technically I could get 72 embryos in this thing at the same time, and it would treat everybody exactly the same way and take all their pictures and give us all the information. What we try to do at our center is put the patients who would most optimally succeed and use the technology in the best way. We generally start no more than 3 of them per week, because what I didn't talk about is the fact that they actually live with us for almost 7 days. So with that period of time, we wouldn't get a new opening in the machine until that person had gotten out. So we start about 3 patients a week. So we can do more than 1. We could potentially do all the way up to 6. However, we want to give everybody the chance. Now, not everybody has 12 embryos. Some people have 5 embryos. Some people have 13. So I got to put 1 all by itself alone in another little slide. However, it takes up then 1/3 of the machine. So we always have extra space so that we can treat the patient and have all of their embryos in here till we can get the information. So we actually can see quite a number of patients per week. We leave it up to the physician and the patient to some degree to decide whether they want to use this technology rather than our standard. Our standard is pretty darn good in itself. However, whether we're going to use this or not, we find that it has the most optimal use for patients who have either failed a cycle before, because we've gained information about it. However, this provides us with way more information about what may not have gone correctly, and we can pick out those ones that have divided incorrectly and know that those ones weren't going to work anyway. So you gain a lot of information, and you can see what might be the problem. We put a second set of patients in there, ones that are not willing to do that invasive technique of pulling out cells and counting the chromosomes. They don't want to ever go to that, which very clearly it's not my decision to do it. But this allows us to then still select with the best chance of minimizing the chance that there would be an abnormality in the genetics, so we can use it to pick out the most optimal embryo that we can see with just morphology. And then there's the ones who are fairly young and produce a lot of eggs and make a lot of embryos. It allows us to rank them basically from the absolute best number 1 versus number 2, which probably is pretty darn good, but may not be just as good as the first one, where I showed that picture of 4 of them. All of them made blasts. We would have potentially put any one of those 4 back at that point. We actually knew which one was the best and which one was the second best, and so we can rank them all, because we really do only want to put 1 normal back at a time, 1 normal healthy pregnancy, 1 normal easy delivery is really our goal. So it helps us select out the really best one when they have many. We reduce the chance of having genetic abnormalities, and we can really see when things aren't going right. We can have reasons for that. We can review it with the patient and the physician and go through and say, this is where it divided incorrectly. This is where it showed too many nuclei. This is where it fused. So I didn't even show you, but sometimes cells fuse back together. A very backwards, which in what we do, it's not really known that cells would ever go backwards and fuse back together, but time-lapse technology allows you to see when they do something abnormal like that. So the types of patients we see that. And then there's the ones who just want to see baby's first video, as that one is. And so, yes, we have these records, they're there, and yeah, this is basically the earliest video you could ever get of your future child. So that's the last set of patients are the ones who really want that special video. We do treat them if that's what they want.
Thank you so much.
In the beginning, you mentioned that one of the things you try to do is limit light exposure. I was just wondering, what is the nature of the light or some other element to take the pictures?
All right. So when we pull them out once a day, we sort of live in this little dark, no windowed environment in this lab. And the lights that are up in the ceiling when we're out and the light that's on the microscope all have made sure they have no ultraviolet range of light wavelength being out, because it is absolutely known that it will break DNA. Unprotected DNA is shattered by ultraviolet light if it hits it. And remember, when you have very few copies of the DNA, if you break one, it doesn't repair well or may not repair at all, and that does not lead to a normal genetic child then. So what they did, I didn't do this, Fertilitech did this. They went through and they actually figured out that because they knew exactly where those pictures were going to be taken, they could take all 3,500 pictures of an embryo during its 6 to 7 days of development, they could take all those and be less light exposure than if I took it out one time per day into a normal light environment. So less exposure to light inside the machine than it would be outside the machine. And yet I get about 3,840 more pictures. And so I can gain a lot more information without exposing them to any more light whatsoever. So it's really that ultraviolet wavelength that matters. And so there is light field, which is what this picture is taken with, and then dark field. And so you can see cell membranes differently in dark field, but the Fertility people decided to go with light field microscopy, which is what pretty much the standard of most places are, but that's what we use also in our normal thing. But you can see all the brightness, and so light is shining through the embryo, and you can see the cells based on that. Whereas dark field, you wouldn't see what's in the cells, but you would see just the membrane around it. One of the other technologies of time-lapse does use dark field. So they don't gain the information about that micronuclei and things like that happen, but they are easily able to count the cells, but they can't actually look inside. That's what light field or bright field allows you to see.
That was a concern that when we went through our FDA clearance and the studies and all the testing and whatever, it's about 12, the embryos, it's about 12% less light exposure than with traditional IVF.
So yeah, we really do care about light, and they as a company spent quite a bit of time before it ever rolled out and got approved. This is the only approved time-lapse technology in this country. The FDA has not said yes to anyone else's attempts at this because of the concerns. This is the only one that's actually available clinically.
Thank you. Have you seen an actual increase in live births for women, especially over the age of 40, by using the embryoscope?
All right, so as I said, we put different types of patients in here based on what the physician and the patient interaction is and what they want to try to get out of it. So to actually look at specific numbers, I would have to do it randomly. I would have to put some of the 40-year-olds pluses in one and some in the other technology we do, and do them side by side, and then do a number of them and then find out whether that increased or decreased the pregnancy. So at our center, we have not done the approximately 5,000 cases you would have to do in those two groups to see a difference if there really was a giant difference. But the consortium of all the centers who have used this have definitely looked at the data, and it absolutely improves it, between 15 and 20% overall. So at our one individual center, we haven't seen nearly enough patients to prove it in our hands, in our machine, in our way. However, for all the people who use this technology and use this machine, when they put all theirs together and get like 20,000 cycles together, they've absolutely shown that it increases pregnancy rates. It allows you to pick the one optimal one and to not put in all the ones that divided incorrectly that you would have never known in the standard culture. So anything dividing 1 to 3 or 2 to 5 or any multinucleation situation, we would never see that in the normal culture. And once you see it, you know not to put that one back. That increases your chance of success of the ones that you do put back. And so that's why there's between 15 and 20% increase.
How come some doctors put back an egg after 3 days? Does that mean that it divided really, really quickly if it was a grade A?
All right,
After
so
3 days.
that's some people call it a cleavage stage transfer. Some call it a day 3 transfer.
Right.
Yes. So, so we used to grow them only for, well, actually, if you really go back in IVF, they used to actually have the sperm and the egg and put them back right away that same day. It works, not really super well, but it works. Then they found that they could grow them overnight to get to that 2 pronuclear stage, so you can actually see that it has chromosomes from the male and the female, and put them back at that stage. And that worked better than putting them back just as what is called gametes. Those are called zygotes, and they were putting those back. Then people got better with culture. They had better media, they had better incubators, they monitored things more carefully, and they found that they could actually grow out 2 or even 3 days, and now you can get to that approximately 8-cell stage. So at 8 cells is when it actually turns on the genes inside the embryo itself. Before that, everything up to 8 cells is completely controlled by the woman. That's normal in life, isn't it? So everything is controlled by the woman and what she put into the egg at the beginning. Those first 3 days is totally under her control. Only at that point does it actually turn on the DNA and start to use that DNA to make decisions as it divides for the next couple days. So by getting all the way to 8 cells, approximately that third day, the cleavage stage. We could really pick out the ones that were making it that far, developing, and showing that they started the activation of the genome of the embryo itself. So that was a very good stage to develop to, and it showed improvements when growing for 3 days and putting those ones back over growing for only 1 day and growing for no days. Technology has definitely continued to advance. We've gotten better media, we've gotten the better nutrients that they like, the less exposure to light, things like time-lapse technology. We can now grow them for 5 or 6 or even up to 7 days long and actually allow them to help us tell us which ones are still going to make it. What was sort of found is that embryos on day 3 or cleavage stage, even if they were the good ones from, let's just say, 6 cells all the way to 10 cells, somewhere in that range, they showed that they're developing fairly normally. Even if we take just those, only half of those will make it to a blastocyst. So if nature's going to select out half of them, I'd like to actually see those half that aren't going to make it and not put those ones back. So on day 3, we would have to put back in 2, 3, 4 or more potential embryos because half of them would never even make it to the point where they could be transferred and or would implant in the uterine lining. So if we grow them for the next 2 days approximately, that allows us to be able to let nature tell us which ones are still working, the new genome is active, and it's still developing to a blastocyst. So it increased implantation, so each embryo implanting. It increased that by almost double. So day 3 versus day 5, and it makes it a blastocyst. So we go to blastocyst unless a patient absolutely refuses. We really want to go to the blastocyst. We want to see that it's met all the time point development, it's activated the genome, it's formed a blastocyst as it's supposed to, and we even want it to start to hatch out of there. And if it doesn't hatch out by itself, we use a little technique with a very, very small laser to cut a tiny little hole in there called assisted hatching. But it allows us to make sure that that embryo is still alive when we put it back in, is developed the most normally, and has the best chance of being genetically normal. And the uterus is also ready for a blastocyst. That's about the point that it's going to head down there and be able to be outside and implant in the wall. If I put something back too early, it's just going to sit there and wait and wait and wait and wait. And finally, 2 to 3 days later, it might hatch out 50% of the time, and it might implant. Whereas if I put the right thing, that I've eliminated the 50% that weren't going to make it, and I've put it right there, right receptive, squished in there, because the uterus is really squished down. It sits in there, it's held right there, and it can and work its way into the uterine lining right away, not sitting around for a couple days while you go jogging and everything else.
So on that point, would the doctor wait if that blast was that good after 3 days? Shouldn't he have waited the extra couple of days?
You're going to want me to say something about other people's practice management.
No, I'm just.
I'll say it this way:
Yeah.
there are different reasons to transfer it back earlier. If there's very few embryos or only one.
Yeah.
What do you gain by going 2 more days? I will argue that you gain the knowledge of whether it was going to be able to develop normally or not, versus just putting it back and taking the chance. That is not always the way patients and or some physicians want to go. They want the best chance inside them, and so you can transfer it at that approximately the cleavage or the 3rd day to give it the best chance inside of them. However, about 50% of the time, it's never even going to make it to the blastocyst, and if it doesn't make it, it's never going to work anyway. Additionally, the ones that make the blastocyst are more likely to be genetically normal. So if it doesn't make it there, is there a chance that it might make it inside, but it would be genetically abnormal and lead to an abnormal pregnancy? So I don't want that to happen. So we try to use at our place that unless there's a really good reason, we want to go as far as the blastocyst, even when there's only one. We really want to know that what we're going to put back is going to have the potential to make a baby. And so that's why we generally push that far out. But there are some patients who have gotten pregnant in a different way somewhere else, have heard about this in the future, or only want to go that far, or don't want to. There's all sorts of potential reasons. They are, in my book, in our lab, way outweighed by the fact that we learn which embryos are still going to make it to the blastocyst and have the best potential. Yeah, so technically my timer has gone off, but but I can absolutely off the record do an answer to anything that you have. So that's it for me. I'll be around. I'm Dr. Jason Barrett, and I'll be up in the booth area at some point here in a little bit. All right? B1. Boy 1, B1. That's the booth, B1. All right, thank you.